बस in few seconds now we will go live. Here we are live. So good afternoon everyone. We welcome you all to Ortho TV online, and today we are going to talk on implant selection and total knee replacement. So we start the session with Professor Rajesh Malhotra. Over to you, Professor Rajesh Malhotra.
Thank you. Good afternoon, everyone. Thanks, Nilan. And thanks, everybody else on board.
Pleasure.
I'm going to talk about the implant selection. And, there's a wide range of the X-rays which we see. But really, before I choose my implant, I choose my patient. So you must first know your patient for knee replacement. And we always have a few questions to ask to decide whether the patient is ideal to undergo the knee replacement surgery. And once that is done, and we see that it's a unicompartmental disease which is got bone on bone. We actually like to sort of give the option of unicondylar knee replacement versus the HTO. Anup is going to talk more about it. But then the ideal candidate is one who has anterior medial osteoarthritis with posterior medial cartilage intact, lateral compartment intact, ACL intact, correctable varus, and they will always get the UKR. So we'll leave the rest of it with Anup. Now, who's an ideal candidate for TK? The one who, in my book, the one who needs replacement surgery was not a suitable case for UK. And there's a whole range of implants to choose. Of course, I know that I have to make a case for CR knee, which I do, but then I just want to put everything in perspective and show you that there's a lot to choose from. And what we have to know is the anatomy of the knee, all the important ligaments and the important structures, and know that there are 6 degrees of freedom in the knee, and the joint moves as a combination of all these freedoms. And we have to realize that there's a difference between the native knee and the replaced knee. And in the majority of the designs, actually, all the replaced knees are ACL deficient knees. So the majority of them are not able to provide you biomechanics like a native knee. They only try to mimic. And when we are choosing this, you are trying to restore the biomechanics as close to a native knee. And the three important factors are conformity, the constraint, and the kinematics. Now, basically, conformity is the congruity of the articulating surfaces in which the concave poly insert conforms to the convex femoral component. Constraint is the resistance of an article surface configuration to different motions. And usually it's for rotational or translational. And the kinematics is essentially the geometry of motion. It depends on the degree of conformity and design of the constraint. So these are all interlinked. So we can have the cruciate retaining knee where the PCL is retained, or you can have the posterior stabilized knee where the PCL is not retained and is substituted, and the insert in these cases is more congruent. Then, of course, if there's a collateral insufficiency, you have to go for some kind of constraint. And when there's a global ligament insufficiency, you go for a hinge knee. So this is an overview of the implants which you use. So let's talk about the PCL being intact. Now you use a CR knee. The advantages are the bone is conserved, no post-cam impingement, restoration of joint line, improved proprioception. If you want to remove it, you can either go for the anterior stabilized insert, like I have said before and say again, or you can use a PS knee where you make an additional cut in the femur, which is a box cut. There's maybe a risk of post-cam impingement, and then it is actually a little more forgiving for the beginners, and it is easier to balance than a CR knee. If the collaterals are not competent and there's varus valgus instability, again, you need more resection. So think bone also when you are choosing your implant. That's what I'm trying to say. And then global insufficiency, again, there's a hinge. Again, my colleagues are going to talk more about it. Now, I just want to make a point about the downside of a constraint. So this was a lady who was bedridden for almost 10 years and she had bilateral valgus knee deformity. So I used a knee design, which was a PS knee, but it allowed the constraint option in the insert. So you use something like a PS knee, but you have an insert which is CCK. She was heavy, and she this was her immediate post-operative X-ray, and then on day 9 she had this. So essentially, what happens is that when you are increasing the constraint, you must remember that it is actually transferring the stresses to the host bone. If the bone is osteoporotic, like it was in this case, can give rise to a premature failure. And when I went there, I found hardly any bone there. It was all crushed, and I had to use a distal femoral allograft with the constrained kind of knee with the femoral stem. So the choice of the implant really depends on the anatomy and soft tissue envelope. Implants with less conformity and minimum constraints are preferable, because I showed you what happens when you increase the constraint where the bones are not so strong. You try to achieve near native biomechanics, and you must try to conserve bone. It's an important message I want to give. And then it depends on the age and the bone condition. Now, if you have a case where the PCL is has to be sacrificed because you can't balance it, or it's incompetent, as happens in inflammatory arthritis or in infective sequelae, and you want to preserve the bone, you can use the ultra congruent deep dish or anterior stabilized or any of the varieties. Essentially, here you're trying to use a CR knee because you're not cutting a box and you're trying to preserve the bone. So the ultra congruent inserts or deep dish inserts are more conforming than CR. They have lived up anteriorly and posteriorly. The patellar replacement is a part of the implant. Usually, people who use PS use it. There can be issues with the clunk, but you can avoid it with the proximal pole synovectomy. But then I prefer to replace petla whenever I'm using a PS design because of the box. But then when I use a CR, one of the advantages is because the joint line is restored, the patellofemoral biomechanics, the kinematics is perfect, and then you can get away without replacing the petla. Stem extension may be needed when there are severe deformities like this. Again, you are going to hear more about it. Just giving you some examples of severe deformities and the bony defect which may need this. The point I'm making here is that I may choose a CR implant, but I must know what kind of stem it will take or whether it will not land me in trouble. What about the newer designs? So this is a paper by Bob Bourne who talked about patient satisfaction after knee replacement. And then he said, the 20% patients are not satisfied. And one of the key reasons where you would like to know is whether the implant which you're choosing is able to improve the patient satisfaction or reduce dissatisfaction. So let's talk about some of the newer designs like gender specific. The high flex knee, which has got a thickened posterior condyle and the wider contact surface for the bearing to reduce wear. So it comes in both CR and PS designs. Same tibia can be used for LCCK type design, which means if the femur fails, you can keep the same stem and go on to the next constraint without having anything to do about a well-fixed tibia. And then basically the tibia supports both standard length and the cemented stubby stem. The cons are the PS design has both box and the pegs, that compromises the distal femoral bone. So if you have PS design, you can use a box implant or you can use a peg implant. Now,
I think Dr. Malhotra has gone offline. Neeraj sir,
Yeah, it seems like that. Uh, is Neeraj around?
can I meanwhile ask a question to the faculty, sir? Or shall we
Okay.
go for the next presentation?
Uh, I think you can ask a question, Anupam.
Sir, this I've always heard that the patient satisfaction is 20%, 25%. I want your opinion from all the faculties. How? how do things work? Like, how do we say this thing, and how can we improve this patient satisfaction, or how can we have a better patient selection so that the patient does not complain after the surgery? Jahangir sir,
Professor Malhotra is back.
So,
welcome back, sir.
okay. Oh, I was gone.
Yes.
Yeah, we lost you.
How long back?
We lost you at the slide of next gen cons.
Yeah.
That it has.
Okay, that's all right. You haven't missed much. So, hello, am I still
Yeah.
on?
Yes, sir. You're still on.
So,
You need to share your screen.
Okay, sorry. I will share my screen. Okay, escape. Mm, do we have to go in again? Just a minute. Cancel and share screen and share. Sorry for the glitch. And so I'm back.
Yes, sir. You're
Everything
back.
okay?
Yeah.
Should we go ahead?
Yeah.
So we were talking about the um, pros and cons. So we go on to the literature review about the high flexion knee, and I said that a good surgeon like Nilan here can give you a very good flexion with the normal implants. So there's very little literature to support that the high flexion knees are really required, and there's some data that it can cause premature loosening of the femur. Now this is another paper on the gender knee, and it said that the post-operative motion gains were identical for men and women. Again, no definite proven advantage for a high flex or for a gender knee. And like I said, there are literature reports which say that the high flex processes does not give any advantage. Now, there are certain newer designs which have been claimed to mimic the normal knee, like Persona by Attune or Triathlon by Stryker. And their claimed advantages are they are anatomical, they improve tibial coverage, decrease incidence of lateral releases, decrease patellofemoral complications, and increase satisfaction. Those are the factors which the newer implant where the companies will play you around. So let's take a look. Again, it's a little unorthodox talk. Let me again take you through from next gen to the entire gamut of the process. So let's talk about the Persona knee. The advantage is that it is available in CR and PS design. It has a constraint option which was not available in next gen. You have an ultra congruent insert so that if the PCL is gone, you don't have to change to the PS. You have an asymmetric tibia with stubby stem design. It offers you 1 millimeter increments in poly inserts, and the femur has both standard and narrow option. The cons are that there's slight, if you end up increasing the slope on the tibial jig, you can lose PCL. So you have to be very careful where you put your jig because slightly increased slope will make you lose your PCL. The stubby stem is very expensive, and then it doesn't support a standard long stem. Now this is a paper which compared next gen with Persona, and it said it did show that the anatomical tibial design improves surface coverage at the medio posterior dimension. So that's a message for this is actually a Genesis 2. But the idea here is that there are papers which suggest that when you're using an asymmetric tibia, you have a much better tibial coverage and force transmission. Let's talk about another knee, Attune. Now that's a new knee available in CR and PS design. The constraint option, it gives you ultra congruent insert to substitute for PCL. Femur has both standard and narrow option, but the poly insert has 1 millimeter increments. However, we have some disrepute regarding the tibial base plate and cement debonding. It doesn't have an asymmetric tibia. It doesn't have a standard and long stem tibial extension in the primary tibia. And the PS design has both box and pegs, which I said is a disadvantage because it compromises both. Now let's compare PFC, like we compared next gen with Persona. Let's compare PFC Sigma with the Tune. The old design and the new design of a company. Now there's a lesser incidence of lateral retinacular release with the Tune. There's less incidence of patellofemoral crepitus with PFC, than with PFC. PFC. This was the bane. Patellofemoral joint was the bane of PFC. Maybe it's patellofemoral contraindicated or something like that. I can think of something, but it meant that it created much more problem in patellofemoral joint. And then there was greater flexion and lower patellofemoral complications but not better overall clinical results according to this study when we compare PFC with the tune. Now, there can be a manufacturer and user facility device experience database, but then there are reports where pain, effusion, and decreased range of motion was reported within 2 years after surgery, and there were 21 reports of early tibial loosening. So since then, it has been said that you can actually improve your tibial cementing technique. This is up for you to decide how much improvement it needs. Now, let's talk about another knee, which is the Genesis 2 knee design. Now, the pros are it has externally rotated femoral component. So you don't externally rotate your cut. Their posterior cuts are equal. So there is no risk of notching of the anterolateral cortex. It comes in both CR and PS designs. It has an ultra-congruous insert to substitute PCL, and tibial base plate has got a longer keel, and oxynium implants are available. These are the advantages. The cons is that the femur does not have the narrow option. So you may, if you land up with the narrower mediolateral extent. What about the Vanguard knee? The Vanguard knee has an advantage that there are very few knees, in fact none, in a PS design, which allows you unlimited compatibility between sizes. And it also gives you very big sizes also of the femur. So anytime you are caught with an extra tall person, the chances are that you may not have an edge size of next gen available in India, but you will have the largest Vanguard available, which can take care of that. The matching options are fantastic. And the whole lots of inserts possibly gives you the widest range of inserts, the CR lip, deep dish, PS plus, and it has got removable lugs. So if you need, you can put lugs, otherwise you can take, and this is the only design which can take augments in the primary femur. So instead of lugs, you can put it. If you need to just build up a little bit, you don't have to go to a CCK type of design. But the disadvantage is that the primary tibia does not support stem extension. You have to put in a revision tibia and destroy a whole lot of bone. There are newer designs like medial pivot and lateral pivot. Medial pivot needs the PCL to be sacrificed in the design which is available in India. We prefer it in inflammatory cases, and the size compatibility an issue because there's no matching available. Size 3 with size 3, 2 with 2. You can put a 2 plus, but then that's hardly ever required. The lateral pivot knee, you can keep the PCL or sacrifice it. Maybe you're better off sacrificing it. It's again preferred in inflammatory cases, but the size compatibility is an issue here also. So there are papers about the medial pivot showing that 94% patients at 15 years were able to perform activities with a mean flexion of 120 degrees, and survival rates are very high, preferred in inflammatory arthritis, and you sacrifice PCL. The 3D lateral pivot, on the other hand, is suitable for use with either maintaining or sacrificing PCL, like I said. And again, there are some claimed the kinematic advantages. Then coming to the other knees which mimic native kinematics, bicruciate substituting and bicruciate retaining. Now, I have some experience with bicruciate substituting. The cost was an issue, but then there are papers which show that it can actually restore kinematic. And it is a very interesting concept. The native tibia is in varus. And if you put your tibia in varus, it will fail. So what this does is it cuts the tibia 90 degrees to the shaft, puts an implant, but uses an insert which is actually lower on the medial side, giving the same inclination at the level of the insert. Rather than giving it at the tibial base plate, which is bound to fail. And then there is bicruciate retaining. The problem with this is that it is very technique intensive because you have to leave a bridge of bone with the ligaments intact, and you have to work like two partial knees, which makes it technically very demanding. So there are reports that knee kinematics with BCS arthroplasty are more or less like a natural knee, which is unparalleled, cannot be achieved by any other design. So it reduces the mediolateral instability in, you heard Jahangir said last time that mid flexion is something which is difficult to understand. But this paper claims that it reduces the mediolateral instability in mid flexion and improves patient satisfaction, no paradoxical motions anteriorly or sufficient posterior rollback, and improve biomechanics. You heard about BCS now, with the BCR also improved biomechanics. So it's not available in India, and there's paucity of sufficient literature. Those are the two drawbacks. A word about the analergic implants, because if the patient has got allergy to the implants, you will need to put in either an oxenium knee. Only femur is oxenium. This is titanium. And then that's something like the 30-year knee, which they say, or the AS Gold knee, which is available with the Vibron, which is actually this kind of coating actually also available with the lateral pivot 3D knee. But those are the advantages with them. So design consideration, CR or PS, basically, this very nice paper, I'll recommend reading it. Basically, if you can't retain PCL, that will not be a reason for me to go to PCL, because then I will just use the UC insert. So why I changed over to CR, my boss, Dr. Bhan, used to do only PS knees always. But then there is poor bone quality in Indian patient. That's a case in favor of CR knee. There is no box cut. Look at the amount of bone which is removed in a box cut. It's a patella friendly thing because there's no box here, so the patella is not articulating or causing a clunk here. The joint line is maintained. It's quicker, and because patella has not been resurfaced, which I hardly ever need in these cases, I don't have a patellar clamp in place, so I can quickly close it. So a lot of you will find a lot of high volume surgeons do a CR knee without resurfacing patella. The fractures are rare and managed more easily. For example, you may have any kind of knee, but the periprosthetic fractures are inevitable. And if you have a CR knee, you have enough amount of bone to, sort of have the osteosynthesis compared to a PS knee, which very often will need you to go to a revision knee. Another example, I had a patient here. I'll tell you here, this was united supracondylar fracture, but look at the offset between these, and there were two scars like this. And now what I did was I used handheld navigation and gave an incision in between, like I showed you. This was the incision I gave, trying to maintain a bridge. I didn't go far down, and this is the implant I could get. You can start seeing some threads of the lag screw, but I didn't remove anything from this side except for the compression screw, and I could get a perfect alignment because of the handheld navigation. But then if I wanted to do a PS here, I would have not only been forced to sort of redo this osteotomy, align it, and then I would have been left with very little bone. I could just use a CR and get away with it. And I've got numerous such examples where CR comes to your rescue. In inflammatory arthritis, again, these patients are often young, they have poor bone quality, muscle wasting, intraoperative fractures can occur, infection is a high risk. The knees have got severe deformities, bones are small. And again, in these, because of the anticipated surgical challenges, I almost never do a PS design. I do a flexion deformity. If there's a flexion deformity and I need to recut the femur, I put a disc insert and short tibial extension to take care of the poor quality bone. I often use navigation system in these because of this paper which we published, because it reduces the embolic load. So that helped me decide my implant also for some age group of patients. So how I choose my implant is, first look at the age, less than 60, 60 to 70, more than 70. All patients I always examine for suitability for partial, particularly in patients less than 60 and those who are above 70, and all patients above 80, I try, even if I have to stretch indications, to do a partial knee. So the implant selection will depend on the anticipated surgical challenges. I have told you about the inflammatory joint in the young patient. I'll not go over it again. 60 to 70 depends on the pathoanatomy, surgical challenges, CR or PS, and bilateral TKR if no medical condition, like I said earlier. But what I do is I look at the pathoanatomy and surgical changes, and these more constrained designs will be discussed by my colleagues. But if there are no medical conditions, this is not a problem. But if there are medical conditions, then I always use navigation, and that dictates my implant selection. And I prefer, as far as possible, if I can't do a uni, I do a CR with a disc insert. In group 3, which is more than 70 years, again, see if the UKR is possible. If TKR, it's always navigated. And then I try to avoid the PS design, and I never do bilateral TKR. So to conclude, we have variety of knee implants. The important thing for you to know is know the advantages and disadvantages of whatever knee implant you choose, because there's no implant is ideal. Don't try to fit your patient to the implant. fit the implant to the knee. And I have such training of my residents in my unit that if I show them an X-ray and show them a patient, 9 out of 10 will agree, and they will not tell about the only one kind of implant. Whatever implants I have showed you, they are all used, and they make a choice depending on the patient factors and the knee factors. But we try to improve kinematics and satisfaction, but we know nothing is perfect. You must know, like I said, advantages and disadvantages of what you are using. There are multiple factors like age, medical condition, type of deformity, surgical challenges, bone quality, which you have to consider. Do not generalize one implant to every patient. Fit implant to patient or not patient to implant. Preferable familiar prosthesis should be used if there are more than one option for the given condition, and choose your own implant as per patient's need demands. So choosing an implant for orthopedic surgery is like choosing a wife for a bachelor. It should be long lasting, predictable, wear less, familiar, adaptable, good for age, put up with eccentricities, forgiving, relatively expensive, difficult to dispense with, and it must deliver. Thank you very much for your attention. You have to either choose the best one or remain happy for the whole life, because if you go wrong, you'll have to get a new one again, and then there's no guarantee that it will last you the rest of your life. Thank you very much for your attention.
Professor Malhotra, thank you very much. It was an extremely exhaustive and an entertaining selection of implant, especially the comparison to the wife. Now, I think questions we'll have later on. So now whether we should go ahead with Jahangir with his PS talk, or Anup, are you dying to give your talk on uni? Hi, Anup.
Whenever you want.
Yeah, so maybe we'll let Jahangir talk, because since Total Knees have started.
Sure.
Jahangir, can we have you?
Sure.
Give your talk on PS knees.
Sure. Thank you very much.
As everybody knows, Jahangir is a big time orthopedic and arthroplasty surgeon in UK, in Harlow. And we are privileged to have him here. Jahangir.
Thank you very much, Nilen. Thank you for that. And thank you so much for the invite and to the organizers. Implant choices in TKR. It was excellent that Professor started off with all the options. And it really exactly will say what I'm going to probably say in most of my talk. So let's start. Now, the plan of my talk, let's start with the basic science. So I'll start a bit of the basic science and cover a bit of what Professor had said. Let's put into perspective true evidence-based medicine, which we are supposed to be using. The worries about bone loss, fractures, is it there in which type of knees? And just because I'm a really committed PS user, I'll try to give my tips on how I try to improve long-term survival and try to do away with many of the points which Professor had said happen in PS knees. So I'll tell you what I do. Now, I completely agree with the Professor that really in our training, in our fellowships, you should be versatile. Every knee, you should know how it works and what it works and actually do it yourself. However, in Harlow, myself in my practice, as well as what we dictate in Harlow, is all knees are standardized. And by standardized, I mean not standard knees. We use a knee implant which allows a versatility for any type of increased going up in the complication, going up in what we have to use. So I want a knee system which I can use augments, stems, straight up, which is there on my shelf. Okay, so that's what I do by standardized. Straight away, all knees are posterior cruciate substituting knees. All patella are resurfaced, yes, and all posterior are preferencing. So what is the pedigree? I mean, what is the pedigree of myself and Harlow for PS knees, so posterior cruciate substituting knees? Paul Allen, my colleague who started the knee service for knee replacements, April 1994, very clearly, everything was on a database, prospective knee society form, society's forings form and X-ray evaluation form, all right? All the knees from then on to now, from 1994 now, are all PS knees. Yeah, it's not that we've not used CR, and I'm very grateful that Professor had put in charge how CR can be used, but I'm just telling you all the knees were PS. We just want to know how they would do in the long term. So in myself personally, I've not done a CR knee for 20 years, all right, not even one. Commenced PFC Sigma in 1998, and we'll talk about Attune if we have time in the discussion, but I just want to stick to what I'm doing. The diagnosis, as everywhere, as Nilain said, Rajesh had said, that there will be osteoarthritis, there will be a rheumatoid arthritis, but because I'm using PS knees all the time, I use it for all my knees. Let's just start with the basic science. Truly, if you really truly look at the literature, there are no true long-term studies for survival. I'm talking about survival, which will truly put one over the other. Because if it was, then high performance surgeons like my colleagues, faculty, Anup, Rajesh, and Nilain, who do a combination I know Nilain does more CR, but Professor who does both. If we had true long-term survival studies, I would have to change, or one of them will have to change. All right. So the answer that I'm allowed to give a platform to speak on PS knees means let's accept there's no true long-term evidence for that. As Professor had said very clearly, we have these bi-cruciate retaining knees. They're non-mainstream, and therefore in a virgin knee, we accept that the ACL and the PCL act together, all right? And that's responsible for what is called as true rollback. And true rollback, I'm not talking about how much the condyle, medial condyle pivots or not, but true condyle is the posterior shift of the contact point of the femur and the tibia as the knee flex, all right? So there is a rollback. Now, in every knee we cut the ACL. We agree that's what we do. So if we cut the ACL, then we have to accept that at least in cinematic studies or in the lab, when we are looking at pictures of people deep flexing, there will be a combination of roll, but there unfortunately may be a degree of slide, which in the basic science level may be detrimental. I'm putting it in brackets because it's not proved out at all, but therefore a PS knee has a post and cams, and the word which is correct to use is a predictable rollback. All right, so you have a predictable rollback, and the insert will be conforming. For my colleagues who are fantastic surgeons, I'll go to them to have my knee done, and I'll have a CRD done if one of them is doing it. Who are on the faculty, I'll say, they use a PCR knee because the polyliner is not flat. That was old design. It's now conforming. Okay, but there may be a degree of what is called as paradoxical slide, but issues with that are not borne out for either long-term survival studies or patient-reported outcome measures. The three studies I use as a simple orthopedic surgeon, all right, I want to know whether any long-term implant survival studies, so truly, like I said, there's no, and true patient-reported outcome measure studies have not clearly showed a benefit of one over the other. Okay, so this is a bit on evidence-based. And therefore, let's go back to what we had all discussed in our previous talks. The end result of a knee is not PS, not CR, not knee, is correct bony cuts, correct rotation, correct sizing, and correct balance, okay? Irrespective of which knee we are using. And we have to have the armamentarium for that, but these are the most important issues. Let me just go into my key steps, if you don't mind, on how I do a PS knee. First of all, there's no formal templating, but I draw on the board or on my screen digitally my midpoint of my femur for my entry point. In my talk on approaches, and we all talked about it, when I prepare my femur, irrespective of osteophytes or not, I make a square box so that I get a perfect entry point for my femur. I'm not saying you can't get it in a CR, but it's easier to get in a PS knee, and I do that. So that's what I do. Once I enter, because it's a square target, I'm very clear that my entry point mimics what I want or where I want to go. And I make sure that I don't flex my component in this type of implant. I don't flex. Okay, so this I can put my guide wherever I want. Second, in truth, this is the answer. In a PCR or a PS knee, is there a difference in the amount of distal femur cut? Now, if you traditionally look at correct release practices of balancing flexion and extension, if you release your PCL, the flexion gap increases by 2 millimeters or 1 millimeter. Okay, that happens. The answer, therefore, is if you want to balance your extension and flexion gap, because inherently by cutting your PCL, if your flexion gap has increased, you need the correct amount of distal femoral resection to match that. Hence, Professor had said in one of the previous talks that 1 or 2 millimeters of extra resection of the femur is not going to make a difference to your joint line. So I do it all the time, but I'm telling you very clearly, it's not raising the joint line, which is bad. It's 1 or 2 millimeters. Hence, I do that. So I add on a millimeter or 2 more to a distal femoral cut. And that's to balance my flexion gap because I'm a complete PCL substituting surgeon. Many of the other CR surgeons may go back and do this step, but I do it straight away. So let's go on. So I've now cut my distal femur. I check whatever you want to check. You can do navigation. You can use your normal conventional flat. Next, where are we with sizing? And I thought I'll just introduce this as to what I do. And then if there's open for discussion, I'll very much like to know what my colleagues do and whether it makes a difference for PS or a CR in what type of referencing use. So just to introduce referencing, there's a posterior referencer who says, I will never violate my flexion gap. Okay, so you're never going into your flexion gap. That's someone who uses posterior up referencing, which is myself. The anterior referencing person says, I will never notch my femur. Okay, these are two fundamental differences between referencing. I use a posterior referencing up, which is my jig. That's your posterior up. And as I've said before, when does it make a difference? It only makes a difference when you're between sizes. If you're a straightforward 3 or 4 or whatever implant size you are on your system, it doesn't matter whether you're posterior up or anterior down. And with newer systems, it's very correct. There are more inventory, and this issue of what you do when you're between sizes is becoming less and less. But just as a point, because we will be in situations where we are between sizes, and you need to know in your implant what works best. If I am between sizes, so I'll tell you what I do. So first, this is my posterior up referencing. I'm on the bone. Let's not talk about valgus or rotational problems. Let's accept we've got our correct rotation. I'm very clear, as I said, I reference off the anterior cortex, not off the lateral cortex to get my size right. And I never want to oversize. So in between sizes, you have two choices. You can either go for the larger size and accept that you will not notch. And maybe in patients like the Indian patients where you're worried about fractures, that may be something we do, but I like your views on that. But I don't like to oversize, especially on my medial lateral part of the knee. And therefore, I always use the correct size of the implant, but I mark for the higher size so I don't notch. I'll talk to you about the pros and cons of what you're doing with that. But in knee replacement surgery, as Professor correctly says, no implant is ideal. You choose the better of your two devils, but know what you're doing. So that's my philosophy of what I do in knee replacements. So let's carry on. So I've cut my condyles. And now this is the time when I've cut my anterior chamfer. I've done my chamfer cuts. And because I'm a PS surgeon, I remove my osteophytes here. I've already removed them earlier, but I do another check now. So that's my next check now for my medial lateral osteophytes. And now I have the option, because I'm a PS, I can change my medial lateral position of my implant now if I have to. Where are we with the slot cut? Okay, so now because I'm a PS surgeon, where I have to make my box cut. Yes, it is removing bone, but let's say where are our worries? Too much bone, but in my hands or what I do, even in my smaller knees, I have not changed to a CR. I agree, like I said, if you're really in the scenario in India or the Far East where you're worried about osteoporotic fractures, which is a true issue, very smaller knees, the whole gamut of knees is smaller, I completely take the point, but I tend not to change. And when we come to revision, right, there's no evidence that when we are doing a revision, yes, those CR knees, we would use, yes, less of a sleeve or more of a sleeve. That depends on your osteolysis of where you have it. So from the bone loss, I do it in my smaller knees. Second is a worry about the fractures. Yes, it may be there, but as I said, in my smaller knees, I don't change. And the fractures I have, I would say condylar fractures are more than supracondylar. And I'll tell you how I get around that in my troubleshooting. And distal femoral fractures, I'll tell you where it happens. So my femoral preparations, I place my slot cut. I put one pin here. I put another pin in, but I don't hammer it down. And this one, right? This one, I started using a short pin, and I don't use two. So use a short pin on your anterior cortex pin. Okay, so that's what you can do to avoid one. And when I use my saw, see my hand, I tend not to, my fellows and registrars, you shouldn't move your hand. Let the saw do its work so that you don't undermine and fracture the condyle. So that's what another tip for that. Troubleshooting the PS knee. Now you want this. You want the femoral component trial to sit on the bone there. Let's say it's off the bone. Many people, when it's off the bone, they will try to say that my problem is my distal cut. In a PS knee, it's not the distal cut. It's how deep your box cut is. You have to deepen it and then you'll get this down. So that's one point. Second point is, where do you get your fracture in a PS knee? Like I said, I've had very rare. I've had one of each, and the fracture I had is when you start putting your trial on and you made your box, when you hammer your implant on and your medial lateral part of the box is not wide enough and you hammer the implant down, you'll get a fracture which propagates here. It'll be this fracture which propagates because you've split your condyle because of the box. That's what I feel happens. Tibial slope, yes or no? I don't know slope in a PS knee. So all my knees have no slope, but I make sure there's no upslope. Why? Very clear, because I don't want to have to compromise my valgus varus cut, because I don't know where the front of the knee is, and hence no slope for me. That's my advantage. I know in CR you'll have to, but in my PS knees, you don't need to. Where are we with patella resurfacing? Yeah. Fracture, and I resurface every knee. There's no evidence, but I feel some knees don't do well with a virgin knee, and one of them is PFC sigma. I have no evidence for that. And like Professor said, PH knees we should be resurfacing. So I resurface all. And what are the points? I'm center on my mediolateral, and I'm center on my superior inferior, and I make sure I'm 90 degrees to my long axis. So I do this. I don't want to be here. I don't want to be here because it's an oval patella. And where are we with clunk? And I'll finish with this. Do we get patella clunk? Yes. The victim of success, I see it only in knees which flex greater than 120 degrees. And the diagnosis, it should be 12 months. They should be happy patients, and they should have a mid-flexion crunching. How do I avoid that? I work very much on this area. I dissect this area in the quadriceps tendon. I remove all the tissue here. I do a formal patelloplasty on every patella resurfacing. And I'll end with, which Nilain is going to talk on, is if you have a knee like this, where you need things like offset trays, etc., should we be using PS knees with stems rather than a CR? So thank you very much.
Jahangir, thanks a lot. Your thoughts have been very, very clear. Clear message that PS works and standardization helps, and resurface all patellae. Here also, we'll probably have the questions later on. And Anup, your choice. Do you want to go ahead, or you want me to give the talk?
You have to tell me. You are the boss.
Okay, then maybe for a change. Haji, Malhotra साहब.
नहीं, मैं कह रहा था कि अब आपने नी शुरू कर लिया है तो आप नी खत्म कर दो, फिर उसको पार्शियल देते, because why do you have the last word always?
Yeah, even I was thinking of the same thing.
Sure.
Yeah. So I'm just going to share a few thoughts about constraints and stems in knee replacement. Just by using a stem, you won't get a good result. Using a constrained knee, you will not get a good result. You have to use them properly and in the proper case. So constraint The word means a restriction or a limitation. So in the total knee context, when we use the word constraint, it means that this is going to restrict the scope, the extent, or the activity of pathologic knee motion by mechanical substitution for the normal stabilizing function of soft tissues while still allowing flexion and extension. That means either varus valgus will be limited, the flexion distraction force will be limited, but the flexion extension will still occur. So classification of knee implants can be unconstrained, semi-constrained, varus valgus constrained, or fully constrained, and they may be unlinked or linked. So when we use the word cruciate retaining, we need to understand that there is no posterior or collateral or translational stability to this knee, which is generally given by the soft tissues, and somewhat this is helped by the conformity of the articular surface. PS, the word PS means posterior stabilized. So it by the word itself, it means that it is going to give you posterior stability. It gives you minimal collateral stability and translational stability. Constrained will give you AP stability, more collateral and translational stability, but still you would require reasonable gaps. And then you have the hinge knee, which is stable in all planes except flexion extension. As Jahangir said, that CR and PS knees, most long-term studies have shown equivalent survivorship, and the term semi-constrained, which was once utilized for PS knees, is practically now dropped, and nobody calls a PS knee as semi-constrained, and they are both used as relatively unconstrained knees. So traditionally, when one talks about constrained implants, varus valgus constraint or the hinge is what one means. So the basic fundamental principle of a knee replacement is to use the least amount of constraint that is consistent with stability. If you think you are going to get away with a partial knee replacement, keeping all the ligaments intact and not landing up with any complication of a partial knee, that can be very good. Or when you are doing a total knee, if you can get away with doing the minimally constrained knee replacement, which works in your hands, but which is stable, which is well aligned, with patella tracking well and well cemented, that will work well. Now, why this knee also does not satisfy the patient fully, as Professor had said in that Bob Brown paper, that 1/5 of the population of knee replacement is not happy, that is still a matter of debate. So ligaments and soft tissues are wonderful elastic structures that can absorb stresses and decrease the loads on the fixation interfaces. So the lesser constraint you have, the greater is the likelihood that the knee will last more. So now I have kind of limited myself, because the need for constrained implants in primary total knee, at least in my hands, is not huge. And I would use it only if soft tissues are irreparably incompetent in the present time, preoperatively or intraoperatively. There is a mishap and it appears that the soft tissues have become incompetent, or they are likely to be incompetent in the future. So in my practice, this is less than 1%. I'll share an example that I had done years ago. In 2006, this lady I had operated. She was 54 at that time. Looking at these x-rays, obviously we did a neuro consultation. We did some EMG nerve conduction. She was a non-diabetic. She had a dislocated patella, as you can see here, and it was a grossly unstable knee. We labeled it as neuropathic, but the cause was undetermined. I did a parapatellar approach. I put a condylar constrained knee with a tibial augment and stem. The femur was unstemmed, and we also did a lateral release. Now, this is a 2-month follow-up. This is the corridor of Bombay Hospital. This is a year follow-up. And I saw this lady recently. Also, this is just to show that the knee, which was so grossly unstable, the cruciate condylar knee managed to stabilize it, has remained stable. And the patella also was tracking well. And on the whole, she's had a very satisfactory long-term result. Now, if you have disruption of soft tissues intraoperatively, the most common structure that is injured is medial collateral. The literature says that it can be as high as 8% in obese and stiff people. Lotke says that the incidence is 2.2 in general hands, 2.2%. Obviously, it decreases with greater experience, but highest incidence in morbidly obese and stiff knees. So this is what at-risk knee appears like. It is stiff, osteophytes are present, patella baja is there, and the lady is morbidly obese. The injury can often go unrecognized because the medial stability and extension is maintained. So unless it is tested in flexion, this will be missed. This is an extremely important point that you need to check when you are doing a knee replacement, to check the stability medially and laterally, not just in extension in 10-15 degrees of flexion, in 90 degree of flexion, and in mid flexion as well, so that you can pick up subtle MCL injury. I also believe that a lot of cases of the so-called mid-flexion instability may be those cases where the MCL has been damaged partially. What is the hallmark of a total MCL injury? A difficult exposure suddenly becomes easy. Flexion gap becomes huge, especially if the PCL is excised. Femur externally rotates on the tibia at 90 degrees. It is grossly medially unstable on valgus stress test. And if you palpate it, how do you palpate it? You put your fingers between the gap between the femur and the tibia, and you palpate medially, and you will be able to feel the disruption of the MCL. You need to distinguish MCL tear from an over-release. In an over-release situation, the gap between the medial tibiofemoral gap and the lateral tibiofemoral gap will still be symmetrical. You will not be able to palpate any tear, and you can manage this routinely with a larger poly, and you may brace them. With an MCL tear, the gap will become asymmetrical. The medial tibiofemoral space will be huge. You can feel the tear, and management is definitely not routine. You may have to repair, reconstruct with semitendinosis, or you may have to use a higher constraint. And that is where a constrained implant or a PS plus implant may also become useful. A primary MCL injury, end-to-end suture in normal constraint, partial MCL injury suffices. But you need to repair before the final insert is placed, and you need to brace. But there is no literature confirmation about what is partial, whether it is 10%, 40%, 60%, that is not really defined. Mid-substance laceration, repair if PCL is intact, repair and augment, reconstruct with semitendinosis, or use a higher constraint. I'll share an example of a lady, 82-year-old, where I had done a PS knee, subvastus, everything looked good, but I had done an overzealous medial release. This is a case which I had done around 15 years ago. And she ended up, after a fall, with a grossly unstable knee and gait difficulties. We managed to revise only the femur with a varus valgus constrained and a stem, and the medial ligament was repaired with anchors, and she has remained stable and satisfied. As Professor Malhotra has shown, the varus valgus constrained knee will have a thicker and a longer post to articulate with the femoral box, which would also be deepened. But different manufacturers have different types of cam and post mechanisms, but this is the underlying concept. The earlier hinges which were available were simple hinges and they failed due to loosening and bone loss. The current successful hinges are all rotating hinges, the endoclinic hinge, the rotating hinge knee, or the SROM Noyles hinge, etc. Here the hinge is fixed to the femur and not to the tibia. It is attached to the tibia by a long hinge post extension, and rotation in the hinge mechanism is allowed. Hence, this will reduce stresses. And these are some diagrams of a modern hinge. In certain cases, you find that although the soft tissues are currently okay, they are likely to give way in future. I would caution you that whenever you're doing a varus knee, where there is a fixed hindfoot valgus, then this lower extremity is going to be subjected to consistent valgus forces, and you may consider primarily to put in a varus valgus constrained knee. Similarly, if the patient has gross scoliosis or abductor insufficiency or neuropathic joint, as I have shown, there should be a slightly lower threshold to put in a varus valgus constrained knee. When you are seeing recurvatum knees with weak quads, say post polio limbs or something with arthritis, they are not common, but they are there. I have operated. Then you should think of putting in a rotating hinge knee with an extension stop to prevent recurvatum. When these concepts are not understood and knee replacements are performed in even patients with paralysis, this is the type of problem that you can land up with, and we want to avoid these things. So we need to understand the limits of unconstrained implants. Now, a few words about stem. What does the word stem mean? A stem is a central part of something from which other parts can develop or grow, or which forms a support. So why do we need stems in knee replacement? They aid in fixation, they help in alignment, they impart rotational stability, they offload the metaphyseal region, and they reduce stress at component bone junction. This concept by Haddad, the zonal concept, is very, very good, in which you divide either the femur or the tibia into epiphysis, metaphysis, and diaphysis. And for your implant to be remaining stable over the years, you need at least good fixation in 2 out of the 3 zones. So epiphysis, metaphysis is good, epiphysis, diaphysis is good, but 2 out of 3 zones, you need to have good stability for the implant to last. So tibial stem in primary total knee, if you have epiphysis, metaphysis, which is defective, and what is a very, very simple test on table is that if you put a trial and if you can rock it by hand by putting actual pressure over it, then that means that you probably need a stem on this. If the patient has gross osteoporosis, or if you have used a higher constraint, then you would think of a tibial stem. Obviously, if you have put in an augment, a major augment, or you've grafted it, also you would think of putting in a tibial stem. Similarly, femoral stem, if there is deficient epiphysis, metaphysis, if you augmented it or grafted it, again, gross osteoporosis, or if the press fit trial implants appear unstable, you would put a femoral stem. Some people have been putting in stems in morbidly obese patients also, but I don't think that the literature is still clear whether you always should or you shouldn't. Stems are much often used in revision knee replacements, and it is obvious there is bone loss, there is soft tissue and ligament incompetence. You want to improve the fixation, you've used a greater constraint, then the role for stems is much higher. The controversy is the method of fixation. whether you should use cement or press fit stems, and the length and the diameter of the stem. There have been good reports of cemented stems in the literature with results as long as 92% survivorship at 10 years using cemented stems. Similarly, even press fit uncemented stems have had good results in literature with 80 to 90% survivorship at 7 years. So stems could be metaphyseal engaging or diaphyseal engaging. Metaphyseal engaging are generally cemented. They do not dictate the implant position. They are easy to do. There is less micromotion because of the cementation. There is a lesser risk of fracture. You can do it even if the diaphysis is altered. And typically the length is 30 to 100 millimeters. But these can be difficult to remove and they do not dictate alignment. So you have to be careful that you are aligning it well. This is an example of a metaphyseal engaging, short and stubby, fully cemented stem. Diaphyseal engaging stems can be the uncemented press fit stems. They will aid the alignment of the knee replacement. They can dictate the implant position. They are often offset. But by putting in too tight diaphyseal engaging stem, there's a possibility of fracture. You cannot really add any antibiotics to it, but these can be easier to extract. Typical length is 75 to 200 millimeters. Various thicknesses and longer stems will be offset and curved. They may be slotted and of titanium to reduce the end of stem stress shielding and pain. How long should they be? If you are using a press fit stem, minimum 4 centimeter of press fit with adequate canal fill ratio is what is recommended. And what is this canal fill ratio? The width of the stem over the endosteal diameter of the stem tip needs to be more than 0.85. That means what it means is that it has to be a tight fitting stem and minimum of 4 centimeters of this, engaging the diaphysis for the stem to really be solid inside. What is the technique? You take the entry point, which is the continuation of diaphyseal axis. It is very often not the actual center of the knee, but you have to look at a long leg X-ray of the femur in AP and lateral plane or of the tibia similarly and find out where would be the entry point. Then you gradually ream from low to a higher degree until you get an endosteal clutter. That means when your reamer is going there, you can feel that the reamer is engaging the endosteum of the bone, and then you can use an offset or a curved stem, and it should be so tight that you cannot really put the trial implant by hand, nor can you remove it by hand. You need the special removers to take it out. The hybrid fixation is the best of both worlds. Stem is uncemented in diaphysis, the articular surface is cemented, and the metaphyseal region can be reconstructed with cones, sleeves, graft, or cement. I'll just share an example of a revision knee. This is a failed total knee. At 7 years, the infection markers are normal. On table, we found that the post was broken. There was severe osteolysis, but no evidence of infection. This is after the femoral component is removed. Particulate debris and bone loss can be seen. The femur is cleaned. It's like an ice cream cone. Damaged epiphysis and metaphysis. The tibia is loose. Absolutely, you can move it in whichever way you want. So the tibia is reconstructed, allograft bone, aligned and sized, complete reconstruction. We did it through the subvastus approach, and post-operatively you can see that the stems have been used, the sleeves have been used, bone has been grafted to improve the metaphyseal area, and she has remained well and satisfied. Another example, a mobile spacer which was infected, hybrid fixation. and we put in stimulant. And she's also remained stable. So in conclusion, I would say, friends, that we need to use constraint as required. There should be a low threshold for using stems, which can be cemented or press fit or hybrid, but stability of the implant and stability of the implant in the bone is the key for long-term success. I thank you for your attention.
Thank you, Nitin sir. That was a very fantastic presentation. Anup sir, can you go on with your presentation now?
Sure. Okay, so thank you once again. And we've heard the total knee talks, and we'll just look at knee from a little different perspective. And let me first share my thoughts of how a beginner arthroplasty surgeon thinks about the knee. And this is what he's telling or asking all of us. So tell me, oh my teacher, what should I do? Could I cut the fiber in the front without much ado and put in a third of a knee so that the knee can do what it can do? Or should I put in a total, keeping intact the fiber at the back? Or can I cut both the ropes and throw them in the sack? Tell me, oh my teacher, what should I do? So this is the quandary with which most arthroplasty surgeons are faced. And we need to take it step by step. But before we come to partials, I'd like to take HTO out of the way. A lot of people think that the cases for high tibial osteotomy and uni are the same. They are not the same. They're two different operations and for two different indications altogether. This is the classical case for a high tibial osteotomy. The joint space and the cartilage is well maintained. The varus is extra-articular. Now, high tibial osteotomy is an extra-articular operation, and uni is an intra-articular intervention. So if the angle of deformity is below the knee, if the cora is below the knee, with well-maintained joint space and cartilage, unilateral disease, male patient, this is just the right indication for a high tibial osteotomy. So let's take the high tibial osteotomy first out of the way by saying that a male patient, young patient, extra-articular deformity, cartilage intact is a good case for high tibial osteotomy. And uni is often compared to high tibial osteotomy, but the survivorship of high tibial osteotomy is about 80% at 10 years. We all know that they'll need a revision 10 to 15 years. While the survivorship of uni in good hands, we'll come to that, is about 95% at 10 years. But two different operations for two different indications. That's the first moot point. Uni, having said that, is a very controversial and contentious operations. And we need to define the right indications. We need to see how are the long-term outcomes and how we can improve them. And what is the data, outcome data compared to a total knee or high tibial osteotomy. First, the indications. It is for anteromedial arthritis of the knee, which you have to define. What is medial compartment arthritis of the knee? We all know that the weight-bearing axis passes medial, and a lot of us have constitutional varus, and that leads to medial compartment arthritis. Now, initially, the anterior cruciate ligament is intact, and we see them whenever we open a knee. If the anterior cruciate is intact, there is no loss of cartilage, full thickness in the lateral compartment. The disease is confined to the anteromedial compartment with an intact ACL, and the knee can open in a valgus stress, which means there is no permanent contracture of the medial collateral ligament. That's the right case for a uni. So that's very important. Let me just repeat and re-emphasize. You take a valgus stress in 20-degree flexion. If the knee opens up with normal cartilage space, unlike a weight-bearing film like the two you see here, that means there is no MCL contracture, the ACL is also intact, and this is a good case for a uni. Moreover, the medial tibial condyle should be intact, and you can make that out on the X-ray. If the medial tibial condyle concavity is intact, that means ACL is intact. If ACL is not intact, then you will have a posterior translation and the medial tibial condyle will flatten out, and that is a contraindication. So this is the way a classical MCOA knee will look like. The lateral compartment will be intact. There'll be full thickness cartilage loss on the medial side. The patella will be intact on the lateral side. So if you have medial facet changes, those are acceptable, but you have lateral facet changes on the patella or lateral condyle changes, that is not a case for uni. So these are very important considerations when we define a patient or indications for uni. Questions are, and a lot of patients ask these questions, that does arthritis progress to the lateral or PF compartment after we do a uni? Data from Oxford and other groups suggest that once you arrest the arthritic process on the medial side, the patellofemoral and the lateral compartment functions pretty well at 10 years. There are a few caveats to that, and we'll discuss that. But anteromedial OA is a focal disorder, and we should look at the knee in that way. So whenever you see a bone-on-bone disease medially, don't jump to a total. Think about it, especially if it's a young patient or a very old patient. Think about it. Can you do with less? And we can with a good uni. Couple of case examples. This is a 50-year-old doctor with medial compartment pain, bone-on-bone disease, opening up on valgus stress X-ray, patellofemoral joint, good young patient, nicely counseled, and an Oxford knee or any other mobile or fixed bearing knee with right technique will give excellent results. This is an 80-year-old male with osteochondrosis of the medial condyle. You can see that with comorbidities, opening of valgus stress. Here you can take an MRI to ensure that the lateral compartment is okay, the ACL is okay, it's not inflammatory pathology. One has to rule out inflammatory pathology if you're planning a uni. This is a classical osteonecrosis of the medial femoral condyle, corresponds to changes on the tibial condyle, and you can treat with Oxford uni or any other uni. Now, Oxford knee has shown to have a long history, wonderful long-term results, especially in the hands of designer surgeons. Equivalent results in some expert hands, but not so much in registry data. It has about 90% survivorship at 15 years, especially in designer hands. And there are distinct advantages of doing uni. Quick recovery, it can be day care or one day, especially with this COVID outbreak. We should be re-looking at unis because it's a smaller procedure, less average length of stay. Patient can be discharged early. There is less blood loss, better functional outcome, and sporting activity. Important thing is to identify the right patient. Now, the registry data that we often look at is questionable. That means that all unis or fixed and mobile are pooled, and it's easier to revise a uni. That's why it shows a higher revision rate. And it's paradoxical that Oxford is best in New Zealand registry, but third in the Australian registry. And why it is so? Because all the unis are pooled in, and because it's easier to revise a uni, it shows a higher revision rate of about 30% in some cases at 15 years. Now, the question regarding fixed and mobile bearing, you can see this is the British Joint Replacement Registry, this 2017 report, but even in 2018 report, the fixed and mobile revision rates are the same. So if you can see the purple line and the blue line, they are more or less same. So the revision rates of fixed and mobile bearing, when it comes to overall general population of surgeons, it becomes the same. But in expert hands, it is better. Now, what are the failure modes? The failure modes are that in mobile bearing, the failure mode is usually progression of the disease on the lateral side, because you tend to make it little tight because the bearing is, it has a concave curved bearing. So you tend to make it a little tight and the disease progresses on the lateral side. while on fixed bearing, it's usually progression in varus and the failure of the tibial component, especially the tibial pin. If it causes a stress fracture, that is also a mode of failure. So what are the issues and how can we improve on some of these problems of unis? Especially we can improve on the longevity. We can improve on implant positioning, gap balancing, and hence the longevity. And we can improve on the function. These are certain areas that certainly need improvement. And that is why we have evolved from conventional unis to robotic. So we have got robotic, well, we are doing it for last 2 years, but there are results of robotic unis up to 8 years in the literature. And robotics are often criticized in advertorials or in editorials for being marketing gimmicks or being too expensive and time consuming. But let's leave that debate apart and see the science. What is the real science behind robotics? Because it's machine learning, it's deep learning. More important, the pooled data becomes smarter because of artificial intelligence. So most robotics are able to pool the data in and become smarter, give us more valuable information as we move on. Classical bilateral case, bone-on-bone disease, opening up on valgus stress, less than 10-degree varus, less than 5 degree of fixed flexion deformity, nice knee, just disease involved medial compartment. I'd like you to draw your attention on the orange line. The orange line is way above the midline. That means this knee is very lax. And this is very valuable information that the robotic arm gives us that normal conventional feeling doesn't. Now what we need to do is to bring that orange line near the midline. I mean, this has to open 1 or 2 millimeter throughout the range of movement, and we don't have to correct the full varus. From a 7, we can correct it to 3 or 4. And that's a great advantage of robotics, that you can actually mimic the normal knee motion, especially in flexion, because flexion kinematics are difficult to decipher and difficult to replicate. And this valuable information of getting the knee right there where it belongs, that sweet spot, is very important. And you can see that you can change the femur component positioning just like in total knee. If your extension gap is tight, you can bring it forward, bring it superior, resect more bone. If it's a hyperextension knee, you can distalize, resect less bone. If your flexion gap is tight, you can anteriorize and increase your flexion gap. All those things are in your hand, unlike a conventional uni. And that is why it's such a valuable tool, especially for unis. And this is the result of that bilateral patient. I've shown that picture not as a show off, but to show you that at 3 to 4 weeks when the patient comes, that's the kind of range of movement of near full flexion that you can have. Similar patient, same indications, AMOA, intact lateral compartment and ACL, less than 10-degree varus. Now here, paradoxical to the first case, you can see that the orange line is below the midline. That tells us that knee is very tight. If the knee is very tight, you can resect a little more bone, as I said, take the femur components superior and interior to open the spaces so that the orange line comes just above the midline, opening 1 or 2 millimeters throughout the range of motion. And this is very valuable tool for us to have that kind of motion where you come to about 3-degree varus, you don't overcorrect and you don't leave them in 5 or 6 degrees. So around 3 to 4 is just the right amount of normal varus that the patient would have. And that's the kind of opening that you would have around 2 millimeters throughout the range of motion. Again, same kind of results when the patient comes early. Now, X-ray just gives us a 2-dimensional static image of the knee, mostly in extension. What we need to know more is flexion, behavioral, kinematic pattern of that particular knee and to replicate it. And robotics helps us do that. Let's go through this small video. I'll just highlight the important steps. And if it works. Sorry for that. Okay, so that's the classical indications that we have discussed. about 10-degree varus, intact lateral compartment, intact ACL. And the first step is to register by putting the pins. We don't use a tourniquet, so the field may appear a little bloody, but intact lateral compartment. And then we register, give all the information of the kinematic pattern under stress to the computer, and the robotics tells us what that. I'm not able to control it nicely. Oh. Give me a minute. Do I have a minute? I'll just.
Anup, take your time, huh? Take your time. No
There
issue.
is a. Yeah, I think.
I think whilst he is organizing that video, Jahangir, do you want to answer what Anupam had asked? That do you think that in your practice, 1 out of 5 patients are unhappy? And
Yeah. Thank you very much for letting me start on that. I know it's said 20%, but I really feel that it's not in my practice, I don't think so, but compared to my hip replacement practice and all of us who do knees and hips, it's very clear the hips are happier patients as a group. But I don't think we should have a 20% dissatisfaction rate. And my answer to that comes down to true patient selection. I think that comes down purely to that. And in UK, both privately and NHS, we have a bit of that luxury. And I'll tell you my point for patient selection. If we see a patient who we know, the minute the patient walks into a room, we all know as experienced surgeon, this person may not do well. That could be a combination of factors, patients saying, put your lights low in the room, my eyes are hurting, or pain, other parts of the body. These are the patients we know won't do well. If you don't have night pain, if you don't have a walking distance of 10 minutes, and your x-rays are classical for a knee replacement, those are the 3 criteria I'm happy with. If you're not happy with these 3, then what I have the luxury for, I pull out that patient. So I see the patient, I say, look, I'll see you in 3 months, I'll see you in 4 months, you're not ready yet, you won't have a good result. And my goal is 1 year to pull him out. I can do it, I can't go for 1 year, but that's my goal. And once I go on telling a patient you won't do well, and once I do it, he'll never complain to me. That's my philosophy of trying to counsel the patients. That's one. And secondly, is in your group of patients we treat, there's some points which I don't want. So I'll never have a tight knee. I want them always to be straight. My unsatisfactory patients, my early years of my consultant practice have been those knees which are left with a few dizzy of a residual flexion. So that's one. I want perfect x-rays so no one else will revise my knees. That's the next thing. Let's aim for perfect x-rays, perfect alignments. And then if a patient has pain, no one will revise them. I don't discharge my patients. That's another luxury. There's no shopping around in the UK. Even privately, they'll come back to you. So I have the luxury that if a patient's unhappy, I really stay with my patient. So every 6 weeks, in the end, I go on talking to the patient, and that's where I keep my dissatisfaction is less. Thank you, Nilay.
right. I think giving time to a patient is extremely important. And it kind of becomes counterproductive because as you get busier, finding time gets more difficult. But the less satisfied patients are not necessarily less satisfied because of the surgery. They may have some unaddressed emotional issues, and they basically want somebody to listen to them. So as long as you just listen to them, you can reduce the dissatisfaction. That has been my experience. Professor Malhotra had said that the implant choice is like a wife. And sometimes I think knee replacement patients are also like a wife. You have to patiently listen to them without offering a solution if there is no solution in sight. Prof, do you want to say something?
Yeah, I think talking about the dissatisfaction, so those are Western figures, and I'm sure none of us on this panel really have that higher dissatisfaction rate. And I got a few theories for that. One, of course, like Jay said, that it's the patient selection. you choose a patient who's not bone on bone, a patient who's not disabled, the patient who's actually whose symptoms are out of proportion to the X-ray changes which you see when you operate on that patient. You are actually buying yourself the trouble. That's number one. Number two is, what I have realized is that many of the scores or the criteria used for dissatisfaction among the Western patients don't apply to our patients. So that's why they never rank so high. Like we don't ask them, do you do gardening? We don't ask them whether you go, skiing, or those are the activities, sporting activity, which are often a part of the dissatisfaction following knee replacement in many of these papers. So keep that in mind. We don't ask them those questions because they don't do it, and that may be the reason why they are less dissatisfied. The third factor is, we did a thesis on the psychoanalysis, or the looking at the psychological profile of the patients, and we found that the single widowed women are the most dissatisfied. And in Germany, it was said that if you had a redhead teacher by profession, a redhead lady, and who particularly was paying for her own treatment, the odds were that, the 80% chances are not only she'll be dissatisfied, but she'll sue you. So we did this thesis, and we found that, the patients who had very high score for kinesiophobia, and that's the fear of moving the knee because they feel they will cause pain, or pain catastrophizing scales which are there. So those are the factors, like you said, you yourself said, emotional factors, the psychological factors, so much so that, in Glasgow, I was it was 2010, I was with Khalid Saleh on the dais, and he said at that time they were doing a psychological profiling of all the patients who were coming for knee replacement, to know that whether they have any psychological factors which will give rise to a dissatisfied patient. So yes, there's a lot. So when we talk, I agree with every technical point which Jay said, but here we are talking about a patient being dissatisfied when you have done a perfect or near perfect surgery with perfect X-rays, and those are the issues there.
Yeah.
Anup is connected to the audio.
Yeah.
Is again gone. So any other questions, Anupam? What do you think?
Sir, I have a question from the audience. Just a second. Is it possible to see in the X-ray which company's implant design has been used? This is a question from the audience. I would like the faculty's opinion on this question.
I think if
No,
I
it
may
is
answer that.
possible.
Yeah.
Yeah.
Please,
Sorry.
Professor Malhotra, go on.
No, it's all right. I'm sorry. I should have waited for you to go ahead. I just said that, if you are familiar with the X-ray picture, it's possible to tell in a great majority of cases, and I can understand why you want to know that, because many times the patient and we don't know what implant has been used. And the second thing is, I think in UK and many other places, people are actually now developing an app or a software by which, you can just scan an X-ray with your phone, and it will tell you the design or the make, and that is essentially done by putting in the data of a lot of post-operative X-rays of the different knee designs. But by and large, as of now, it will be your familiarity with the X-ray picture of the different implants.
Yes.
Sorry, please go ahead.
Experience, yeah, exactly. By experience, you know what implant looks like what on radiographs. So you know what it looks like. I think Anup is with us now.
Yeah, I am on the phone, so I don't have my computer access because it's not connecting from there. I'm sorry for that. I don't know what's going on. But,
No issues, sir. No issues.
So I can answer the questions, but I can't show that video at the end. But I think that's okay.
So we discussed about patient satisfaction. So do you have any comment on to that, Anup, sir?
Sorry?
We discussed the question of patient satisfaction, that 20% of the patients are pretty much unsatisfied with the surgery. So do you have any comment on to this question?
Well,
How
I
is
think
your
that number is decreasing, and the current incidence is about 10%. I would say 10 to 12%, and not really 20%. And it also depends. I think the satisfaction rates with unis are better.
Okay.
Yes. I mean, if I may ask a question to the faculty, that supposing you know that despite everything what you have done, a patient is not happy and he's going to come to the clinic. Now, and you have some other 10 patients to see in the clinic as well. Now, what is your strategy to make that patient happy, as long as not make the other 10 patients who are waiting to get operated by you anxious in some way? And since Anup wasn't with us, we'll probably ask Anup first, provided all his knees are not unis and they are not singing his praises.
No, not at all. Yeah, but I would say generally you should keep separate time for post-op patients. So maybe post-op patients follow-up can come on one day and rest of the day you can see. That's what I do. So I call all my post-ops on Friday only. So you usually finish all your new patients Monday to Thursday. So all the stitch removals, all the follow-ups come on Friday.
Okay. Professor Malhotra, what is your trick?
So I think what Anup is saying is fine, but then, if you have happy patients also, when they come and they are there with the other patient, it can inspire confidence. So what happens usually is, if you have a patient like this, I just tell my assistant that it's bad for business, because now it's going to warn off all the other patients. So what I do is, I don't keep them separate, because I think I want the prospective patients to also see the good results. But what the moment the patient says is, starts off, and the moment they start off, कि डॉक्टर साहब बहुत दर्द है, तो you immediately what you do is you say आप उधर लेटो चल के, I'll just come and see you, so that you send them to another place where you want to examine their knee, which you don't want to do in public. Send them and then go there and talk to them, or else once you know that they have been coming, the last visit they were very unhappy, and you are expecting them to be very unhappy again, and you think that they might have issues, it's best to call them at the end of the outpatient and then give them good time, like you said. That nothing can substitute a good counseling. So that, call them at the end of the outpatient.
Right. Jahangir, what is your trick?
Yeah, I think it's like keep your friends close, but your enemies closer. So the most people will have, who are unhappy patients, you tend not to want to see them. You try to, not be involved with them. My feeling is opposite now. For the last 5 years, the minute I know this patient is going to be unhappy, as Professor said, we all know, then they come into a separate book for me. So I have a list which of patients who are unhappy. I call them at a separate time and I give them time. Paracetamol is good, but not for the patient, for yourself, because you have to hear them moaning to you a lot. So you take that and listen to them. That's there. And once it's done, I see them frequently and on my own. I don't want them to come to a clinic where I'm not there, my assistant see. You see, you have to have one person seeing them all the time. So I have that. I see them regularly on an 8-week cycle probably. And if I want to send them for opinion, provided I'm happy that I've looked in a mirror and it's not my fault, I'm very happy to send them to someone else who I trust. Yeah, so that's what I do. And they are continuously followed up. I will not discharge them.
Right.
Anup sir wants to add something.
Yeah, please, Anup, go on.
Yeah, Nilen, but I think it's also important to rule out any problems with these unhappy patients. So you need to see whether some of them have a fixed flexion deformity or a stiff knee or a poor range of movement, occult infection, all of that. So that is a separate group of patients, which also comes in a bigger bracket of unhappy patients. But
Sure.
those are certain problems that you can solve or at least think about them. The ones which have just pain and can have pain up to 6 or 9 months, some up to 1 year also, are different. But that's something you can't do much except counseling.
Right.
Sure.
Right.
So another question from the audience, this is from Dr. Nikhil Agarwal. He's asking, what are the disadvantages or issues you have with ultra-congruent polyethylene liner?
Yeah, maybe Prof. Malhotra, you mentioned ultra-congruent poly. Any downsides?
Yeah. So I'll tell you what. And now let me, for some time now be on the same side as Jay. We have been sort of on the opposite side for quite long. Though I'll again finish it with something, or at some point make a comment about PSD. For now, what I would like to say is that sorry, where did we start? I'm sorry, I just lost the track.
Ultra
You were talking.
congruent poly, any
Yeah.
downsides?
Yeah. So yeah, that's right. So if I'm asked if I have to operate on a very big VIP, what joint I'll use, I will use a PS, right? So I'm with Jay there, and there's a reason. Why I use CR is not because, and I agree that there can be paradoxical roll forward and all those things with the PCL, because I know that the PCL works with the ECL. The only reason I do CR is because a large majority of my patients have got small bones, osteoporotic, and ever since I shifted to CR, I've stopped having the periprosthetic fractures nearly, unless they have an accident. Whereas we used to have a lot of fractures when we were onto PS, because the design which we're using had the box as well as the peg. Now, coming back to why PS for a VVIP is because the PS has got the most predictable kinematics. So with every design, at 20 degree, 30 degree, 40 degree, depending on how good the design is, the post will engage the cam, and then the kinematics of the knee from there will just roll nicely.
I think Professor.
Anterior stabilized insert is a bailout option when you don't want to do PS at all because there's a very poor bone quality, but the PCL is not there, or you have cemented everything. You were trying to put the insert and you pulled off the PCL. That's why our CR inserts are put in before cementing femoral component. But if that happens, you can put a anterior stabilized. But in some of the studies on kinematics, it's the anterior stabilized knee which has got the worst kinematics. So if there's any relationship between the patient satisfaction and the kinematics, the anterior stabilized ranks very low. So that's not my first choice. My first choice is a CR knee because it's a pretty decent kinematics, not as good as PS, but then not as bad as anterior stabilized. So that's the only thing I have against this anterior stabilized knee, that the kinematics have not been shown to be great.
Right. Now, if I may ask Anup, who has been doing both mobile as well as fixed bearing unicompartmental knee replacements, we talked about choice of implant selection in total knee. So how do you choose between fixed bearing and mobile? And what do you tell the patient? That if you want robotics, I'll do fixed. Is that what you say? Or if you want, good motion, I'll probably do this partial, which has a 30-40 year history.
No, so I've stopped doing Oxfords now since I do robotics. So robotics is fixed bearing. Now, you can't jump to robotics straight away. So you need to have a hang of unis. So those who have to start with a conventional uni, either a fixed bearing or a mobile bearing. Safer to be through mobile bearing because it's more conforming and the long-term data is better. At least with the Oxford, right? Now there are a couple of other mobile bearings which are a copy of the Oxford, but better to stick with Oxford because the newer instrumentation is better, it's more predictable, and once you have got the hang of identifying the right patient, doing Oxford, seeing the results, seeing where you're going wrong and where you need improvement, and you're passionate about unis, then you should evolve to robotic unis. That's my suggestion. That was my pathway at least.
So why did you shift from Oxford to robotics?
No, so I was to buy robotics any which ways because I was doing navigation. I had to buy another navigation because of we run 2 theaters. So I took on to robotics. So now I have both navigation and robotics. Robotics helps us to understand the flexion kinematic behavior of the knee much better than your hand assessment or subjective feel can. So once you assess the flexion kinematic behavior, that chart that I was showing, that plot I was showing, you can titrate your femur implant positioning, your tibial slope, etc., to give a knee which is not tight, not loose, just right. Just hit that sweet spot every time, which you don't with conventional unis.
I understand. I understand. Jahangir, if we may ask you, what is the current status of partial knees in UK?
Current status of
Partial knees in UK.
partial knees in UK, even though it was propagated a lot by the Oxford group, in their hands, very good results. There's no doubt with all papers suggesting that. It's a huge controversy in UK because it was an Oxford invention which was used a lot in that region. That in the National Joint Registry, because the revision rate for a uni was higher, yeah, whether it's justified or not justified, people were doing it easier. Unfortunately, that was a figure there. And I personally have doing less and less near to not. I think in people like Anoop's hands or Professor hands or Nilin, if you're doing it, if you're passionate about it and do it for the correct reasons and do large numbers. And I think in the UK, the message would be, it's going to be done with surgeons who are doing it regularly. Occasional 1 or 2 time using it is not allowed. Officially, you cannot do it unless you have an X number in the UK. Okay, so that's one. Is it controversial? Yes, because people may have good results without doing it, but the number has come in. So it's become a numbers game in the UK. If you do X amount in a unit or personally, then you are allowed, and the CCG, the funding body, will allow it. So that's the message. My subjective non-evidence-based issue of partials in the UK is, and this is non-evidence-based, if you're working in an area where a lot of unis are not happening, right? And you're working with surgeons who are quite aggressive or very good revision surgeons. And if you start doing unis, you might, it's not right, but it might be that your unis are revised because, you know, patient's pain, which we normally wouldn't do for a knee, may be happening with a partial, so I think that's there. But the message is high volume surgeons should do it. Is that the same in India? Is that what you will propagate?
Yeah, I think that is the same in India. That is the same in India. And probably in India, there is much more shopping than what happens in UK. Yeah. So you are always taking a little bit of a risk, but depending upon your reputation and depending upon, how many you are doing, you can probably counter that. Again, it's a numbers game here as well. Prof. Malhotra, do you want to say something on this? Because you also do a large number of unis.
I do a large number, and I have done it on my teacher. And lateral, and he asked me to do it, and he asked me to do a partial. I mean, and he was not a partial surgeon. When he asked me to do it, he had never done a partial in his life. So I can tell you that it is surgery. I'll have no hesitation in offering it to anyone, howsoever important it may be, because I've operated on politicians who were 115 kg and 70 years with obstructive sleep apnea, and I just wanted to do one thing. If I can get away with partial, the risk, and we all know the studies which have shown that the risks of a partial are far fewer than a total. And when the patient is very old or has got comorbidities, then my preference is for partial. I wanted to ask Dr. Jahangir a question. One, that do you think that all PS knees are born equal? And do you think it makes a difference whether the size of the box is same across the sizes or it changes? So I'll give you an example. Like, I have seen that the Vanguard knee takes out the minimum amount of bone for a PS, right? So I say, okay, if I have to do PS, I'm forced to do PS in a patient who's got a poor quality bone. It's my concern as to how much bone I'm removing. And most designs remove a lot of bone. Even the Smith Nephew Gen 2, it gives you an impression that you are leaving a ledge anteriorly, but you actually take out most of the bones from behind with the miller. You don't see the bone, but you see the mill. So one, that would you consider whether, and both are related to my obsession with the bone quality and the bone quantity, would it matter to you how much bone is being taken out? And second, would you rather prefer that the box size changes with the size of the implant, because it means more inventory. But then on the other hand, I think, you don't need as big a box in the smallest size as you need in the largest size.
Yeah, I think that's an important point. And after you told me that, Professor, I took on board without a doubt any knees which are, you will face osteoporotic fractures are an issue. And the whole gamut size of patients who are smaller, then you can understand that issue becomes more important, right? But if the whole gamut size for us in the UK is such that your majority of your knees are in the ballpark figure, which are higher size, then this issue becomes a little less important for me, right? However, changing my implant for an implant which will have a less box cut, I don't have experience of those PS designs, but I take your point that a combination of excessive work like lugs, many drill holes on the femoral side is not good, right? So that's why I put my small points, that less amount of pins, smaller pins, all this relates to combination of lugs or not. So I would not use a combination if I could. And coming down to the fracture risk, I really take my point. And when my juniors are doing it in small knees, 1.5, etc., I'm paranoid about doing that box cut correct. So I do take that as an important issue. And like I said, if you can make your cut deep enough that you're not hammering in an implant trial where you're going to separate and have a fracture, and don't change your saw to move, have a condylar fracture that's there. And that's what I would do for my PS knees. But I want my long-term survival to be a gold standard for a knee I use. So I can look a patient in the eye and say, this is what I'm going to use for you. I think that's what I say.
I think to use a reciprocating saw also is a good trick when you are taking the box cut rather than just the oscillating saw. Are there any further questions, Anupam? Or
There's a question. What is a good implant for a new orthopod to start with?
maybe Anupam, you should answer that because you are the newest of the lot here.
I think so. It depends on your mentor. What you have seen, you probably learn things from your mentor, and I particularly have learned from you that Zimmer Genesis is a good implant. So, but again, I would like your opinion also on this thing, that what should be from the other faculties.
Yeah, I think what you said is absolutely correct. That first you do what you are familiar with, and you can only be familiar with what you have seen again and again and again. And if you have not seen it again and again and again, probably don't do it. And once you have done a considerable number of these, when you have your own experience, then you can probably do something else, considering what the advantages of that other system would be, if any.
That means every system is right. I mean, there is no problem with any system, right?
No, I think most of the systems are right, but it depends upon how we use it. And since we are all individuals, we have our own characteristics. We may be better at using one particular system than the other, because the familiarity comes in this as well.
Maybe I'll extend the question as it, like, if your mentor is a CR surgeon or he's a PS surgeon, you have more chances of picking up his habit, right, of doing PS or CR knees. What does the faculty tell about? Yeah, Jahangir sir, please.
I think what Nilen said was correct. I think more than which implant is good, in knee replacements is very clear. There's no ideal implant. That's the way it is. You choose your evil which you want to avoid. So in case your issue of fracture, condylar fractures, patellar fractures is more of an issue, then accept that's evil you don't want. So you can change for that. But using an implant, use it correctly. That's the main issue. Any implant, just use it correctly. Don't extend your reasons for doing that implant. I would say that's it.
Professor, your opinion, please.
I totally agree. Actually, it's actually the technique which is more important than the implant. All the implants which are currently available have got very good track record, and the single most important factor for you is the familiarity. And there the part of training goes there. And that's precisely the reason why in our teaching institution, we expose our residents to all types of implants. So they learn, they get exposed. It should not happen for a knee replacement surgeon. I'll give you one example. There have been times when we were, when I was not in charge, we were using a particular type of implant. And the dealer will say, sir, we have run out of that insert, that femur, that tibia. I mean, it must be all a news to Dr. Jangi. Unless you are such a big surgeon like Nilen, ordering them around that they dare not, that they'll park their implants in their hospital. So this happened that many times if many times you have when I do say, for example, a particular type of knee which I like, and they say that we don't have right side asymmetric insert of 9 or 10 or 11 millimeter. That's very irritating. And that's where you don't want to be held to ransom by a company, because they think that you can only do their implant, and once they don't supply you, you will have to wait till the next time it will be available. So that's one thing. Training is another thing. So they learn the advantages, just like I told you. The same way they look at a patient, his age, his comorbidities, his bone stock, his height, and bone size, and say, sir, okay, either we can do this or we can do this. So if he is old with comorbidity, they say, okay, sir, I'll do a navigator, right? So this is how the training is. So our reason for not, you will hear this argument all the time from the American surgeons. They'll say that if you are playing golf, you need the same set of clubs every time, otherwise you can't play well. But the problem is this, that you don't get the same set of clubs anyway. The here the problem is the issues availability, the instrumentation. They have two instrumentation. They'll say, sir, the instrumentation is not available. This size implant is not available. So we have a system where, number one, our aim is to let our postgraduate get familiarized with everything so that he can make a choice. Right. So he can't say that I will do CR because I have never seen a PS being done. I will do a PS because I've never seen a PCL being balanced. So we train them thoroughly in all types of implants, showing them which are the benefits of using CR in a particular patient. I showed you an example of that implant where there was malunited distal femoral fracture. Now you can't get away so easily with any implant other than CR. So that's what they learn. On the other hand, I will use hinge also, I'll use PS also if the requirement is there. So these are the multiple factors. But if you are equally good about everything else, you have seen all types, and you want to choose something, I think for a beginner, it may be a good idea to use PS rather than the CR, because it's a little more forgiving.
Dr. Anup wants to add.
Jurani wants to.
Yeah, I think implants and instruments come together. So some of the companies have a good implants, but the instruments are horrible. They're either too big or a little older or not accurate. So implants and instruments should be considered together. That's one thing that I want to add. Second thing is, in our country where there are more deformed patients, the primary tibia should have the option of putting a stem. To me, that's very important. You should not be opening a revision set to put in a tibial stem or a PS plus poly, which we talked about that day. So there are 2-3 things that I want to add, which you should have in your armamentarium of your routine implant that you want to use every day.
Interesting.
A very good point, actually. Yep.
So there's another question. This from the audience. He says this: he was taught that PFC knees have to have a posterior tibial cutting slope of 3 degrees, but I think someone mentioned that there has to be no slope. So can you please clear out this confusion? Yeah, Jahangir sir.
Yeah, can I answer that? Because I think I may have said no slope before. And if one of the papers, which I think Nilen you sent out, I think did it talk about slope? I'm not sure. But the message is that in a PS knee, there's no mandatory requirement for a slope to get your flexion. Okay, that's the message, right? So you don't mandatory need a slope to get your flexion. You need it on the CR, and I'll let that answer happen by the 3 other faculty who use CR. But the message is truly for a PS knee, you don't need slope. Now, why I don't use slope and not the 3 degrees, that I'm telling you very clearly, unless you're using navigation or you're using robotics like Anup does, or the others use navigation, You cannot recreate slope and say, I've got it to 3 degrees, all right? You're doing your best to recreate some slope, but you can't say you've got it back to X amount. So, and the reason therefore I've propagated no slope is that if you truly look at the front of your knee, so we all put our tibial cutting jig on the front of the knee. Now, if you're truly in the front of the knee, which is very difficult to get your jig truly in the front of knee because of your patellar tendon and tuberosity, if you're not perfectly in the front of the knee and you add in slope, right? When you do your cut, you will be propagating your valgus varus mismatch posterolaterally or posteromedially because you're using a slope and cutting not in the front of the knee. So I believe keeping it simple, a PS knee with no slope means I get my perfect valgus varus cut. Hence, I don't use slope, and that's the message. Okay, for that.
Jurani sir wants to add something.
Yeah, I think our patients are different from Caucasian patients, and we have seen Caucasian patients, their slope is not as much as some of our ladies is, which can be up to 13 degrees. Mohanty is published on that. So if we aim for a 0 slope, it will look anterior slope on the X-ray.
Upslope. Yeah, correct.
So for our patients, I think we should try and aim for a 3 or a 5, because if we aim for a 0, it will look very bad on the X-ray at least, if not having any kinematic paradox. You know?
Absolutely. And I think very clearly, no upslope, like that's why I showed the slide. Yeah, Professor Malhotra.
So, two things I would like to say. First message which I want to give is know your system. Look at what your system gives, because what happens is there are some systems which give you no slope in the tibia because the entire slope is built into the insert. Others give entire slope in the tibial cut and don't give you any slope in the insert. And there are others which divide it between the slope of the tibial cut and the insert. So remember that. So important thing is to know the system which you are using, because that's the important thing for you. We know that for CR knee you need slope, and because you expect that the femur will roll back. But then I said the other day, there are many things you learn from the navigation. I gave an example that when we make a distal femoral cut, it tends to be extended. So we have learned that when we are not using navigation, to make sure that the blade goes well in the posterior part of the condyle while cutting the distal femur, so that it is not extended. Similarly, the system which I use in navigation is supposed to give 0 degrees slope. And I give 2 degrees only because the posterior tibia is often sclerotic. And when we cut, the blade skies off, very often the kind of blades which we get in India, and they are blunt. And that is a reason for me to actually aim for 2 degrees slope on the cut and check it with navigation, because if I try to keep it 0, very often it shows upsloping because the blade skived through the sclerotic bone. So all those are small technical things which you must keep in mind, that you may not get what you aim because of the so many factors like the saw blade or the sclerotic bone quality and all those things.
Right. I think it's about time for us to close the meeting. It's around 4 o'clock and we had said 2 to 4. I will take this opportunity firstly to thank Ortho TV. Neeraj is here. Neeraj and Ashok, you all have given us a brilliant platform. I sincerely thank you. I thank Anupam for being a co-moderator and the faculty. What can I say? You all have given fantastic answers and really prepared well. Anup, I loved your poems. And in case we can't do knee replacements, your future as a bright poet of India stands. Prof.
I'm already thinking of starting a blog of my poetry so that I'm not unemployed if all this stops.
Great. You can write poems during COVID also.
Does anybody understand Gujarati? Then I'll say a verse. Anup, you'll probably enjoy this.
Please do, Nilin.
क्या मांडू हिसाब आ यातनानो, यानी ये कोविड पे बात किया So by how are we going to calculate the agony that we are all going through? Kya mandshu hisaba yatnano? Kya sarvalo? Kya talo kai male? We cannot add up, we cannot balance, and we don't even know how bad this is eventually going to get. But this has been a little bit of an oasis of sanity in all the bad news that we get. So, Prof. Malhotra, I thank you for being here. And Jahangir, you have been a real sweetheart from UK to grace us.
Thank you.
And thanks again, Neeraj. Give our sincere thanks to Ashok as well.
I'll take the opportunity to thank Dr. Nilen Shah sir for bringing us all together here. I think everyone will agree that it would not have been possible without Dr. Nilen Shah sir's effort. Thank you, sir.
Thank you. Show should go on, but the show should go on.
Yeah, thank you.
Sure.
Thank
So
you.
we reached out to almost 1,000 people via Ortho TV, 1,000 people, and approximately we 10 to 12 people actually asked questions which Anupam actually asked to all of you. So we thank all of you, and maybe we'll see you next week again.
Sir, I'll add up one thing. I skipped some basic questions because it was not the time. We did not have some time, so maybe we'll ask them later, right? Thank you.
Yeah. Okay. Thank you. Bye-bye. And most very last point that we will be sending to all Ortho TV groups and Ortho Books and Journals groups on Telegram. There are some selected articles which we have got from this group, and we'll be sending the full text of those for you to read as a post-class reading. Okay. Bye-bye.
Bye.
Bye. Thank you. Thank you.
Thank you. Bye-bye.